Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
This is Emily Brown, the Program Director at Cancer Support Community Atlanta. Thank you for joining us today for this program on cancer involving the brain and spine with Dr. Kumar Vasudevan. Dr. Vasudevan is the brain and spine surgery specializing in neurosurgical oncology. He is a fellowship-trained, board-eligible neurosurgeon who treats a wide variety of brain and spinal conditions. His interest in neurosurgery began when he was a child, after his grandmother's neurosurgeon stuck with him as the surgeon who helped shepherd his family through the entire process of diagnosis to surgery to recovery. Dr. Vasudevan strives to treat his own patients and their families in the same manner and is to be the home base for his patients and their families and their doctors when it comes to brain and spinal care. So thank you so much, Dr. Vasudevan, for donating your time today to do this program, and I will go ahead and hand it over to you.
Well, thank you very much, Emily. I appreciate it. I'm so happy to be here. I think what you all have going here is such a wonderful resource, and I'm happy to be involved. And thank you for that introduction. What I wanted to discuss today with everyone is cancer involving the brain and spine, which obviously is quite a large topic. But there are certain subtypes which we will discuss, which I think are very relevant to everyone who has a cancer diagnosis or is a caregiver for someone with a cancer diagnosis or helps in another capacity to take care of patients with a cancer diagnosis. And my goal here is to try to give you a little bit of the technical details that we think about, of course, with hopefully not being too overwhelming with those. At the same time, hopefully trying to give you some practical tips that you can think about from the patient care side and from the patient experiencing this. And maybe somebody who doesn't necessarily carry one of these diagnoses, but is aware of it or is thinking about it. And there will be some things along the way that I think hopefully will expose you to some of the new technologies and techniques that we in the field of neurosurgery have to offer, in particular within the Northside Cancer Institute have to offer. And that includes, I'll be showing a brief video of surgeries, of a surgery that I do. So I'll give you fair warning if that sort of thing bothers you, but hopefully you'll find that interesting. So first of all, again, I want to thank you for coming. Such a fantastic group, and I know you all do really great things. You'll see in the bottom right-hand corner of the screen here is my own website and my office phone number. I put that on every slide, and I want to make myself freely available to anybody who views this presentation or maybe is even seeing it after the fact, so that we can try to help if any needs arise. And here is a little bit of an overview of what I'm planning to discuss today. And of course, I want to make sure I answer any questions that might come up towards the end. But first of all, we'll be discussing what is a brain or a spine tumor. And specifically, what I'd like to focus on today is what is a metastasis, which is a difficult to say, but very, very important word within this field. And second of all, what is important to know about cancers in the brain and spine? If you are a patient or helping to take care of a patient with a diagnosis of cancer, what symptoms of these problems do you need to be aware of? And then if you do end up receiving this sort of diagnosis, what are some treatments that we offer, and what does the future of the treatment of these problems look like? And it's such an exciting time to be a part of the field in terms of folks who are helping to treat these patients. And I think the outlook for patients with this diagnosis has really never been brighter. And even within the past 10 to 20 years, there has been a total revolution in how we treat folks that have this diagnosis. I think there's a lot of hope to be had as well. So hopefully I'll be able to impart some of that to you today. I always start with a little bit of introduction for me. So hopefully you understand my qualifications in talking about this. So I'm a neurosurgeon, a brain and spine surgeon. Neurosurgeons typically take care of both the brain and spine. And I have a particular interest and subspecialty training in treating folks with brain and spine tumors, I also treat a wide variety of other brain and spine conditions as well. I kind of bounced up and down the East Coast for my medical training. I was at Brown University in New England for medical school, and then came down to Emory here in Atlanta for my neurosurgery training for a number of years. And I did subspecialty training in neuro-oncology up in Boston at the Dana-Farber Cancer Institute. And then decided to come back here where I've been in practice for almost 2 years now. I have offices in Sandy Springs and at Alpharetta, and I operate out of a number of the Northside Hospital campuses, chiefly based at Northside Hospital in Sandy Springs, but to go to a lot of different campuses. So that's a little bit about me and about my practice. And again, I encourage you, if you have any questions following this talk, a lot of this information is available on our website, as well as information about me. And if you have any questions or would like us to take a look at a case or anything like that, there are ways for you to submit that very easily online. Of course, you can also call our office as well. So I always begin by wanting to issue a few take-home points, the things I hope will stick with you amidst all the details of this presentation. And I'll show these to you now, and they will come up again later on in the talk as well. So the first is that many patients who carry a diagnosis of cancer, unfortunately, are at risk of the cancer spreading to the brain or spine. I will show you some numbers about this in a moment, but it's something that we as folks who take care of cancer patients are hyper aware of, and very attuned to any sort of symptoms or problems that might present this way, just because of how common it is. So you may find that your neurologist, your oncologist, your primary care doctor, your radiation doctor, or your neurosurgeon will all hopefully pay very close attention to any symptoms that might be suggestive of it, and will pursue a workup very aggressively, whether it's pictures, whether it's referral to a specialist, for this reason. And I'll show you some numbers to kind of back up the statement in a moment. The second point that I want to emphasize is that if you do receive a diagnosis of cancer that has spread to the brain or spine, a brain or spine metastasis, then finding the right doctor for you is very important. And the reason why this is the case is because your care after you receive this diagnosis becomes increasingly multidisciplinary. A number of doctors across a number of different specialties have to be involved and have to be talking to each other and thinking about you constantly in the care of this problem. Up until 15, 20 years ago, it used to be a disease process that was managed by doctors that could manage their single aspect of the problem. And as the treatments for this problem become more and more complex, more and more subspecialized, it is my bias and my strong opinion that folks who deal with these sorts of problems day in and day out across, whether it's an oncologist, a radiation doctor, a neurosurgeon, or anybody else, needs to be well versed in these treatments and needs to be talking to other folks that deal with these problems a lot. So finding the right doctor and the right team for you is very important. The third theme that I want to get across is that patients who receive these diagnoses of cancer in the brain and spine are now living longer and more fulfilling lives. And that's because of the revolution in the treatment of these problems that we have had. And I'm going to share some of those revolutionary treatments with you. So hopefully to impart a sense of renewed hope that comes even after a diagnosis like this. And the last point that I do want to address is to help us to help you. And hopefully this is something, if you have received a diagnosis or are helping care for somebody with a diagnosis of cancer, that somebody has told you this before, that we really rely on you all to help us understand what is bothering you, how we can help you, and how we can tailor the treatments that we are providing to fit what is important to you. And that is nowhere is that more important than in the care of brain and spine disease. So I'll start out with a little bit of an introduction. What you're looking at here on the left is a picture of a normal appearing human brain on an MRI scan. And what you can see around the outside there in bright white is the skin. And some of the grayer structures that look all wrinkly in the middle, that's the brain. And that's basically almost a cut taken through the mid portion of the brain. And what you can see there are the various different folds and curves that make up the brain. And you can also see towards the bottom of the picture that the brain leads into the spinal cord. Now, all of our thoughts, all of our emotions, all of our movement, all of our sensation, everything that has ever been created by humankind was generated by this mass of tissue that you see here. It's tremendously important. It fascinates me personally to no end, and that's why I've chosen to go into the field that I have. And this, no matter how powerful this mass of tissue is, it's also very delicate. And we see that when we come to dealing with problems of cancer spreading to the brain, because it can start to affect some of these very delicate functions. And sometimes it does that in a way that is very obvious to you, such as you might experience some difficulty moving or difficulty feeling one side of your body versus another, or you might have a seizure, and that clues us into a problem. But sometimes the issues can be very, very subtle as well. And it speaks to the great complexity of this organ, that you can have all these different variety of symptoms that come from it. In the top right of this picture, what you see is kind of a schematic representation of neurons, which are the firing cells within the brain. These are special cells that talk to each other, communicate with each other. There are trillions of them within your brain. And the way in which they communicate with each other and fire and talk to each other creates all the different thoughts and everything that you experience. And so what you're looking at on the left is kind of the big picture version. And on the right, top right, is the microscopic version of that same thing. Excuse me. And in the bottom right, I wanted to illustrate the spine, which of course is another very important aspect of what I do for a living. And the spine is made up of a couple different things. You see here arrows pointing to the spinal cord, which is something we all think about, of course, as being the information highway that carries signals from the brain down to the rest of the body in the arms and the legs. And surrounding that spinal cord, your body has built this tremendous amount of protection in the form of bone and ligaments and muscles. You see there the vertebral body, the facet joint, the transverse processes. These are terms that I need to know, but for all intents and purposes, they are the protection surrounding the spinal cord. And any of the things that you see in that part of the picture can become involved with cancer, which can have consequences that need to be dealt with. And I show this again to illustrate that this is a picture of the brain now looking at from the outside. Of course, the brain is not colored that way, but we color it that way to illustrate that different parts of the brain are involved in different processes. For instance, the frontal lobe of the brain is involved in a lot of the things that we feel make us human. So our ability to think, to emote, to generate attention for something. To decide what is the correct or not correct action in a particular circumstance, provided by the frontal lobe of the brain. In the temporal lobe of the brain is where a lot of the language functions in our brain are centered. In the occipital lobe, towards the back part of the brain, is where most of our visual representation is made. So depending on where cancer is involved in the brain, we see various symptoms. And what I tell folks is when it comes to the brain and spinal cord, it's often like what folks say about real estate. You know, they say location, location, location is important. And that's very important when it comes to the brain and spine, because not only does it help determine what sort of symptoms you might have from this problem, but it also is very important in considering for us what treatments you might be eligible for and what the positives or negatives of a given treatment might be. So today, I really want to focus our discussion on what we call metastases. Again, a difficult word to say, but very important, in that metastases are spreading of a particular kind of tumor or cancer from elsewhere in the body to the brain or the spine. That is an important distinction because there are also tumors that arise from within the brain and the spine. Those are different, and they're not what we're talking about today. And the reason is, I want to make this distinction apparent to you here. On the left side of the screen are, again, those primary tumors that come from within the brain or the spine. And you oftentimes hear this referred to as brain cancer in kind of common everyday parlance. And on the right is what we'll be talking about, which are metastatic tumors to the brain or the spine, which is cancer that has spread from elsewhere to the brain or the spine. So again, on the left, these primary tumors, they're fairly rare. I see them commonly in my practice because of what I do, but in terms of overall population of folks who are diagnosed with cancer, it's much rarer than other types of cancer. And cancer spreading to the brain is about 10 times more common than that. And again, the primary difference between these two is that the folks that have tumors that arise from within the brain, these tend to be quite aggressive tumors that we treat them aggressively and they can come back in a short period of time. But cancer that has spread from elsewhere to the brain, again, that's the kind I want to focus on today, that has a very well-established pattern of treatment now. And with these standard treatments that we can do, those sorts of cancers can be very well controlled for years on end. And so, again, I want to draw a distinction between these two and again, emphasize we are going to be talking about today the ones on the right. Now, the cancers on the left, that's a topic for a whole different day. And we can revisit that at some point if we need to. So again, they're very different diseases with very different treatments. Now we'll come back to these themes that I had mentioned in the beginning of my presentation. The first one I wanted to talk about is this fact that many patients with a cancer diagnosis are at risk of cancer spreading to the brain and spine. And why is that? Well, what is a brain metastasis? This picture here on the right gives you an idea. Patients that have another diagnosis of cancer, say lung cancer, breast cancer, colon cancer, rectal cancer, or melanoma, really any other kind of cancer can do it as well. They are at risk for that cancer spreading to the brain. And how does that happen? Well, we don't understand exactly why, but we think it has to do with cancer cells escaping where they are in the primary tissue, either in the lung or the breast or the skin, getting into the bloodstream and flowing to different parts of the body. The brain is a very common area to see these because the brain receives more blood than any other organ in the entire body. And so when the cancer cells enter the bloodstream, they can, for some other reason, deposit themselves into the brain and start to grow there. And it is quite in one way interesting to see, because when we do an operation, for instance, and take out these brain metastases from the brain and we look at it under the microscope, it actually looks like a piece of lung tissue or breast tissue or skin tissue that has traveled up into the brain, a ball of cells that should not be there because it's traveled from somewhere else. One thing that I will say, yes, any kind of cancer can spread to the brain. It is very uncommon for prostate cancer to spread there. So we see that quite uncommonly. I have seen it before, but it is rare. Similarly, with spine metastasis, also very, very common in patients who have a diagnosis with cancer. It depends on the literature that you read. Some of them say that up to 70% of patients who carry a diagnosis of metastatic cancer also have spread of that disease to the spine as well. And again, it has to do with the fact that so much of the blood flow in the body goes to the spine because it's such a big structure. And what I want to point out here in the picture on the left, you can see what appears to be a tumor that's growing within the bone here in the spine. And that's important because what I just mentioned is that in the brain, the metastatic tumors tend to pop up within the brain tissue. But in the spine, they more often than not pop up in other areas, for instance, in the bone. And they can grow into the area surrounding the spinal cord. So as opposed to growing within the spinal cord itself, they much more commonly grow around the spine, and they can start doing unhealthy things like pressing on the spinal cord or causing fractures within the spine, things like that that may require treatment. And so that's a distinction between the two. Again, the common sources of these tumors are breast cancer, lung cancer. Prostate cancer, I said it does not commonly go to the brain, but very commonly it does go to the spine if it does spread. So that's a common thing that we do see. But again, any kind of cancer can spread to the spine. So how are these problems diagnosed? Well, there's three main contexts in which they're diagnosed. And the first is that your oncologist may order a test or a scan And even though you're not having any symptoms, so for instance, some folks with a diagnosis of cancer are oftentimes getting PET scans frequently to look for any spread of the disease elsewhere. And sometimes we notice issues in the brain and spine on a PET scan that were not causing any symptoms. It may be that you had a fall or an accident and you get a scan for some reason that's completely unrelated to having cancer. And we detect something that looks, based on pictures, like it might be cancer that has spread to the brain or the spine. Another reason is that the tumor is found because it led to another problem that you did not realize. So for instance, you may not have a diagnosis of cancer already, but you have a fall and the doctor determines that you have a spinal fracture. Well, one of the causes for a spinal fracture potentially is having a tumor in the spine. And so that may be one reason why it's discovered. And of course, the last reason is that the tumor is causing symptoms. And based on an investigation of those symptoms, we find something that leads to this diagnosis. And what symptoms might those be? I think this is a very important slide for folks who have a diagnosis of cancer to pay attention to. So the typical symptoms are things related to something foreign being within the brain or the spine. So the body has mechanisms to demonstrate to us that there's something in those areas that are not supposed to be there. For instance, nausea, vomiting, seizures, and staring spells. These are signs to your doctor, especially if you already have a diagnosis of cancer. These are signs that tell us that there may be something going on in the brain, especially that you deserve for us to pay attention to. It may, necessitate you getting a scan of some kind. Similarly, weakness or numbness in one part of the body. Sometimes that can even look like a stroke. Difficulty walking or difficulty urinating. These are symptoms that, if you have them, should be brought to your doctor's attention, especially, again, if you carry a cancer diagnosis, because they may need to be investigated further. And the last one I want to emphasize is that sometimes the only symptom that we see after cancer has spread to the brain or the spine is just increased pain. So especially if you have a diagnosis of cancer, if you are having a new sort of pain in your head, in your neck, in your back, in your buttock, that is something that, if you are taking medications, it is not responding or it's getting worse, please bring it to the attention of your doctor, because it may need to be investigated. And so don't be afraid to seek help with those symptoms. Now, this is if you do have some of those symptoms, it may lead to getting a scan of some kind. This particular scan is an MRI scan of the brain. And the way to look at this is as if the patient here is lying flat down on their head. And so the front of the head is towards the top part of the screen. And I think even if you're not trained in looking at scans, you can see here that there are some abnormalities. These areas of white that are lighting up are basically areas that correspond to brain metastases. And this is oftentimes how these will look, where the brain is oftentimes studded or spotted with these brain metastases in different areas. And like I said before, it really is just a ball of tumor cells that looks like the organ that it came from when you look at it under the microscope. And so this is a disease that can look like many different things. It can look like many different spots like this within the brain. It could just be one small spot. It could be one large spot. It really takes a designated team of individuals who are used to looking at this to of course, interpret this information. When you look in the spine, this is looking at a CT scan of the spine. So everything you see here that is white is a bone. And so these are the bones in the spine. On the left-hand side, what you're seeing are the bones in the spine that are stacked one on top of each other. And again, I think it's plainly obvious to see there's an area of darkness in the middle of one of those bones. And what that is a fracture that has developed from cancer essentially eating away at that bone. And the picture on the right is basically a cross-section right through that area, where you can see that the bone, the white part, has been eaten away by essentially what looks like a metastatic tumor. So this is what cancer can look like after it has spread to the spine. And in the course of your particular workup, if you are being worked up for this problem, you may get MRI scans, you may get PET scans, you may get CT scans, you may get a combination of all of the above to try to help make this diagnosis. So after you are diagnosed with this problem, with cancer that has spread to the brain and spine, what are the priorities? What do we think about in terms of the next steps of treatments? Well, I like to divide this into two different priorities because I think both of them, of course, are equally important. The first is, of course, to try to alleviate any symptoms that you might be having. So whether this is pain, whether this is any of those other symptoms I was showing you in terms of nausea, vomiting, headache, seizures, those are symptoms, of course, we want to pay attention to. That's one aspect of things. The other side of the coin is, of course, trying to control this tumor growth. That is the first instinct of everybody involved in oncology care is we have a tumor growing. How do we get rid of that tumor? And the paradigm nowadays is shifting where we used to do more and more radical things to try to take tumors out, get tumors completely out, get rid of them. Now we have found that instead of trying to be extremely aggressive, excuse me, in terms of surgery or medical treatment for those, we have found that if we use a right combination of those treatments, we can actually keep tumors under control and watch them for years and years and years on scans or symptomatically and say that, look, the tumor may be there, but it is very quiet. It's not doing anything. It's not causing any problems. And our patients are doing really well with that. So these are two sides of the same coin, equally important when it comes to treating cancer. And that leads me to my next point, which is after a diagnosis of a brain or spine metastasis, finding the right doctor and the right doctor team for you is extremely important. And the reason why is what you see on this slide here. So if you are diagnosed with a brain or spine metastasis, there are going to be multiple doctors that are involved in your care. Highlighted at the top three, at the top of the screen are basically the three that you will probably interact with the most, which are your oncologist, a neurosurgeon, and a radiation oncologist who are providing the therapies that you see there. But of course, we rely on a number of different specialties, like you see here on the slide, and many, many others, to help us in your care. And we really feel, and I personally really feel, it's very important to find a good team of doctors that are used to working with each other, that know each other well, that are constantly talking about their patients with each other to ensure that you're getting the most up-to-date care for yourself. And so now we go back and revisit this slide and say, so we have these two priorities when it comes to care after you have been diagnosed with this metastatic disease. And how do we go about doing that? Well, there are multiple different ways, and I'm going to touch on each of these very briefly. So on the left-hand side, when it comes to alleviating symptoms, the primary ways in which we can do that are with surgery and with radiation therapy. And again, the flip side of the coin, when it comes to controlling tumor growth, we primarily do that using chemotherapy, radiotherapy or radiation therapy, and surgery as well. So we'll talk about each of those things in brief. So the first thing I want to talk about is surgery, being a surgeon. And what I want to say is that, of course, surgery is a very scary, daunting prospect for anybody. I want to assure you that as a neurosurgeon that sees patients with cancer, I do not take that lightly. I recognize how much patients have already been through by the time they come to see me. I also recognize that many times these diagnoses, by the time somebody sees this diagnosis, it may be their first diagnosis of cancer, and I may be the first doctor that is seeing them with this diagnosis. And so I recognize that, and I think that that's such an important thing to keep in mind. You want to, yes, find a surgeon that is a good technician, and that can do physically the act that needs to be done of surgery. But preferably you want to find, again, a tumor specialist. You want to find somebody that understands the full breadth of your cancer care, of everything that you've been through, of all the options that may be facing you going forward. And you want somebody that listens to you and understands what are your goals for treatment. Because as a surgeon, I may be able to offer you something that I can technically do procedure-wise, but if that's not in keeping with what you want for your care, or if that's just not something that is important to you or your family, that is a very viable thing to believe, and that's a very important thing that we need to discuss. And I need to be able to work with you to find something that is going to work if it is not surgery. So I always say this to every patient that walks in my door. Surgery is often the fastest and most effective way to improve symptoms and remove tumors, but it is not the best option for every patient. I have to recognize that, and every doctor taking care of you has to recognize that. But in the right hands, most people do very well with surgery. And I want to emphasize this, saying that if surgery is something that I would recommend for this problem for you, it is because after taking fully into account everything and all the possible treatment options, I feel that any of the risks that might come with surgery are less than the benefits of surgery. The risks are less than the benefits. And I have to be able to tell that to you before we proceed. So what kinds of surgeries are possible? Well, these are two of the main kinds of surgeries that we do for this problem, cancer that is spread to the brain and the spine. If you look at the left, what you see there is a procedure very commonly that I do called a craniotomy, which basically means actually under general anesthesia, opening the skull and going into the brain to remove a tumor. So you see there on the left-hand side, a very large tumor that has grown in the patient's brain. And so what we do, you can see a brief intraoperative picture there. We have opened the skull and exposed what you're seeing there is the surface of the brain. And we actually go underneath the surface of the brain in a safe manner to resect these tumors and to take them out. Similarly, if you look at the right side of the screen, again, we've brought back that picture where the tumor is growing within the spine and is pressing on the spinal cord and perhaps causing symptoms that way. And we can do a procedure called a laminectomy, which basically involves removing part of the bone from the back part of the spine. Again, we do this in a very safe and controlled manner. And that gives us access to remove these tumors that are pressing on the spinal cord, get the pressure off of the spinal cord so that you can be relieved of your symptoms and go on to any further treatment that might be required. And in the bottom right part of the screen, what you see is sometimes what we may have to do in these situations is actually put in some screws into the spine in order to help stabilize the spine. And many times this can help to relieve back pain that might be associated with that. And by way of warning, my next slide has some surgery images on it. So if that sort of thing makes you squeamish, now might be a time to look away for a moment. This is a picture from one of my surgeries that I did want to show you, just so you have an idea of what we do. And what you're looking at here is me operating. And in the center of the screen, you see me kind of working around a small cherry red ball. And what that is a tumor that's in the middle of the brain. And I'm working through the depths of the brain here to try to remove that tumor. And in the silver thing in the left hand that I have there is a suction device. And in the right hand is an electrocautery device. And I'm gently sort of moving the brain tissue around this tumor in a manner that is safe and cauterizing some of the tissue so it does not bleed. So that I can work around this tumor and remove it. This goes on for a couple minutes, so we don't have to watch the entire thing here, but just to give you an idea. So here I am cauterizing some blood vessels, and again, my suction device in the left hand is resting on top of the tumor. What you see there, that cherry red tissue. That's something that's not supposed to be there. So again, we do this. What I'm using now is a very high-powered microscope that allows me to look into the depths of the brain and see all these tissues and all these very important structures very safely. And using our knowledge of the anatomy, we can determine what is a safe corridor to get to these tissues such that we cause no damage or minimal damage to the normal brain tissue in the process. And in some cases, there may be a chance that some of the normal brain function is affected. For instance, there may be some vision problems that result in the course of doing this sort of surgery. There may be some balance problems that result. And this is what I mean by the importance of having a doctor that talks to you about all of these things. Because we should be able to speak to you honestly about this is a possibility, and what is your expectation, and is that something that would be okay with you if that does happen. But by and large, these surgeries can be done extremely safely. There are some areas in which these tumors arise where we cannot do surgery very safely. And again, for those, we have other plenty of good options, and your doctor, your surgeon will discuss that with you. So again, this is a little bit of that surgery. I'll skip ahead now in the interest of time, but that's what it looks like. And that was a surgery that you saw. It opened kind of the skull and was looking into the surface of the brain there to be able to take that out. And I wanted to just highlight some of the modern techniques that we have to really make surgery less of a daunting thing for patients and their families. The first is, this is a newer technique called tubular access, where I can access lesions that are deep down in the middle of the brain by inserting this tube that, rather than destroying or harming any normal brain tissue, it divides the normal brain tissue atraumatically. So I can actually reach areas of the brain that we could never reach before safely. And I can do it through a very, very small opening and a very small incision. And speaking of small incisions, if we oftentimes can do spine surgery, this is an example of one of the incisions that you can see there. It's no bigger than a fingernail. Now, not all surgeries can be done this way, but we have come a long way in terms of finding new ways to do this. Do these surgeries that require shorter length of hospitalization, shorter use of any sort of pain medications, and hopefully a much quicker recovery for patients as well. This is another thing I wanted to highlight. This is something we call an awake craniotomy. Believe it or not, this is a video of a patient who is actually awake during brain surgery. You can see there, we're asking them to do some tasks, drawing on a piece of paper there. And on the right-hand side of the screen, the brain is exposed, and we are stimulating the brain in an area where a tumor is living. So we can ensure that if we take out that tumor, we are not going to compromise the patient's ability to do those things. And we can only do this because the surface of the brain does not have any pain receptors. So this patient is not feeling any pain. At the same time, we can work on areas of the brain that are associated with very important functions and eliminate essentially the risk of harm to those functions. So again, let's go back to here and talk about the priorities after a diagnosis, and move on now to the next step, which is talking about radiation. And radiation goes hand in hand with any sort of surgery or other therapy that we might do for this problem. And the reason being because radiation, essentially what it is a non-invasive treatment method where we shine radiotherapy on cancer cells. And cancer cells, because they divide so quickly, are much more susceptible to being damaged by radiation than the normal cells that exist in a particular area. And so with radiation, we can treat all sorts of microscopic cancer cells that I cannot see in the course of doing a surgery. And so I might be able to do a surgery, take out everything that I can see of an abnormal appearing tumor that's there, but we know that there are always microscopic cells of tumor that are there. And radiation, either before surgery, after surgery, or sometimes even instead of surgery, can help to eliminate all of those microscopic tumor cells. And this radiation is usually given under a radiation, I'll skip this slide, under a radiation oncologist. But sometimes a neurosurgeon also has to help to ensure that radiation is being delivered appropriately and in the correct location and in the correct dosage to be able to complement what we did in surgery very well. At Northside Hospital, we have a very high volume and extensive experience with all different kinds of radiation and radiotherapy. Looking back, there's different types of radiotherapy. Your doctor will be able to talk to you about all of them, but whole brain radiation therapy is one of them, all the way on the left, where the entire brain is treated with different doses of radiation to try to kill tumor cells. And all the way on the right-hand side of this page, you see something we call stereotactic radiosurgery, which basically is something we have access to at Northside Hospital, where we can shine very focused beams of radiation very precisely just on the tumor cells with minimal spillage of radiation to the outside normal tissue. And it allows very, very effective treatment at high doses of those tumor cells. And this is what what the experience is like. So as a patient, you would be here in the top left-hand side of the screen, where we either give you a funny-looking mask that sits over your face, or we place you in a head frame, and then you roll into this radiation machine here that we call a gamma knife machine, and it allows us to shine these focused beams of radiation very precisely. In the bottom left-hand corner of the screen, you see an example of a spot there on the patient's brain that was treated with radiation and essentially almost disappeared. That doesn't happen with every single patient, but the vast majority of patients who have this, we can control these tumors very, very well, and again, prevent them from growing and have them stay stable and asymptomatic for years and years and years. Similarly, we can do that with issues in the spine as well. And here you see somebody undergoing spine radiation, where even if somebody had surgery, it's an essential thing that after surgery, we shoot these areas with radiation to destroy all of the microscopic tumor cells that are in that region. And so that'll be an essential part of your treatment. Coming back to our themes here, patients that have these diagnoses are living longer and more fulfilling lives. And again, I can't emphasize how much of a revolution it has been within the last 15, 20 years for patients that have this diagnosis because of the modern treatment methods that we have. And I have shown you some really high-tech stuff here with regard to surgery and radiation. But believe it or not, a lot of the revolution is happening with what occurs in your oncologist's office. The number of different drugs and therapies that are coming out to help treat these problems are absolutely amazing, and in many cases are saving patients from needing radiation or chemotherapy. And that's why I wanted to highlight them. So here we're going to be talking about chemotherapy. And really, honestly, chemotherapy is a bit of a misnomer for what we are doing these days and what oncologists are doing to treat these problems. So traditional chemotherapy was comprised of a number of different medicines that were very, very powerful, very, very effective medicines, but almost like a shotgun approach. They targeted cancer cells, but also in the process harmed normal cells. And they took a lot out of patients, and they were, of course, very difficult to experience and to go through. And they had a lot of side effects, even though they were very effective. Within the last 15 to 20 years, what has revolutionized our ability to fight these cancers is what we call targeted therapy or immunotherapy. And many of you, if you have a diagnosis of cancer, may have already been treated with one or more of these agents. For instance, targeted therapy is a way of producing medicine. In many cases, they are antibodies, which the body typically would use to fight infection. But now we have basically hijacked them to target cancer proteins on the surface of cancer cells and signal your body to attack those cells and to get rid of them. In other instances, for instance, in forms of breast cancer or in melanoma, there are specific proteins that are involved in causing cancer cells to proliferate and to multiply. And we can block specifically those proteins so that the multiplication does not happen, and we can stop cancer in its tracks. Another form is, again, immunotherapy, where we use your body's own immune system to fight the cancer cells. And the number of different drugs that are coming out to in these classes and other classes to treat these problems, as anybody involved in the care of cancer patients will tell you, is absolutely incredible. And even as a surgeon and somebody who is in the operating room, I really need to understand these and understand what sort of treatment options are available, because that really changes what we do. And I'll give you an example here, which is, if you take a population of folks that have the same kind of cancer, say, for instance, melanoma, we are now at the point where we can investigate that specific patient's melanoma and say, do they have a particular targetable mutation? And say they may have target 1 or target 2, and we have a particular therapy that we can aim at that target 1 or target 2. Those folks will be given those medicines and may not even need to have surgery or chemotherapy or radiation therapy, because they respond so well to those treatments. There are still folks, because we are continually learning more about this, there's still folks for whom we don't have a great target yet for their specific form of cancer, and we may have to still treat them with traditional conventional treatments that of course are effective, but more is yet to be learned about their specific form of cancer as well. And I want to just illustrate here, if you look in the top right corner, this is a patient that had these spots on the brain, you can see on the left-hand side, that were melanoma, metastatic melanoma to the brain. And in some instances, again, if you talk about 10, 15 years ago, this patient would either require surgery or radiation to those areas. But this particular patient was treated only with targeted therapy for their melanoma. And what you can see on the right-hand side of that picture is that those spots have essentially disappeared. So this patient that otherwise would have had surgery, radiation therapy, was essentially put into remission with regard to their disease in their brain by just a medical therapy. And this quote that I put here in the bottom is something that was said to me by one of my mentors as I was going through my training. And I just think it's so important for all of us to keep in mind, which is that our most important job is to continually try to put ourselves out of business. And I think that that is so important for me as a surgeon. Day to day, the reasons why I might or might not operate on somebody are changing. And there are a number of folks who come into my office and their doctor may have thought that they needed surgery. And I tell them that, surgery is not without risk. And I think that there are other great options that are not surgical that we can use to treat you. So this is where it becomes so important to have the involvement of a neurosurgeon, a radiation doctor, an oncologist, and of course, other doctors as well, who are intimately familiar with these problems, think about these problems a lot, because I really think it enables you to get the best care possible. And again, that gets back to this idea of having a large treatment team that understands these problems. The last couple of things I want to say are how you can help us to help you. And I think, I hope these are the most important slides and what you'll take away from this presentation. And here are some issues and some problems that I hope you bring up to neurosurgeons. So first of all, if you are diagnosed with cancer that has spread to the brain and the spine, I hope that you will ask to speak to a neurosurgeon. And I say that even if you may not be somebody may not think you may be a surgical candidate, or surgery is not something you're particularly interested in. A neurosurgeon that is involved in the care of these problems should be able to give you a very honest expectation about what is involved in surgery, or if surgery is not right for you. That is our domain of expertise. So you should be able to ask your neurosurgeon, where is my tumor located? What kind of symptoms can I expect to have from this tumor? Is surgery necessary? That's such an important question. And again, your surgeon should be able to answer that. Is radiotherapy or a medication an alternative to this surgery? And again, a neurosurgeon should be able to give you an honest answer to that question. And again, I think it's always important to ask, how much experience do you have with these problems in particular? That of course, is important for every doctor that you're talking to. And these are the most important things that I would encourage you to ask, which is, what is your treatment goal? A surgeon, amongst any other kind of doctor, should be able to tell you, I have a specific goal for your surgery, whether it's to cure you in total of this tumor, whether it's to take out the majority of this tumor and leave some behind for other treatment, whether it's to stabilize this tumor and prevent it from growing any further. Those are all reasonable goals, and your surgeon should talk to you about that. Make sure you ask about any experimental treatments or clinical trials, because oftentimes we can either set you up with one of those or send you to another place that may have something more appropriate for you. And then, of course, does your surgeon's recommendations fit with your personal goals? And I would encourage you to share those personal goals with your surgeon. And again, for your oncologist, make sure you ask, are you a candidate for medical treatment for your tumor? How will surgery or radiation or medical treatment affect any underlying medical conditions that you may have? If you already have pre-existing heart, lung, kidney problems, how are these medications going to be affected, and how does that change your eligibility for surgery or radiation? What might happen if you choose not to have that particular form of treatment? And how does having this tumor change my life expectancy from my cancer? Again, all very important questions. And if you are a caregiver for somebody, excuse me, with cancer, I don't want to forget about you or leave you behind, because you're an equally important part of this team. And I would encourage you, if you are there with somebody in the doctor's office, if you don't understand something that's going on, ask, because we want you to understand. And your surgeon should be able to guide you step by step through the process of treatment. I always tell folks, because they're seeing a surgeon, and surgery is a very scary, daunting prospect, yes, it is, but I think people are continually surprised that radiation and chemotherapy that might happen before or after a surgery are oftentimes as tough to endure as a surgery, and sometimes even more so. So the person you're caring for is going to require your support all the way through those treatments. And I cannot emphasize this enough. We rely on you as a caregiver to help us understand how your loved one is doing. If you see something that is concerning, we encourage you to please reach out to us to let us know how they are doing and how we can be helpful. And know that you are not alone, and that your treatment team, of course, is available for you every step of the way. And the last thing I'll say is that, of course, being diagnosed with metastatic cancer to the brain or spine can be life-changing. But as I have shown you, hopefully there are some truly excellent treatment options out there. And I hope that you will find the right team to help you and to guide you through them, so that we can really show you everything that we can do, and all the help that we might be able to provide for you as you navigate this process. And again, I would encourage you to head to our website, and if we can be of any help, for me personally, even if it's a non-surgical question, let us know, and we would be more than happy to do so. And I thank you all so much for the opportunity to join, and I think what you are doing here is just fantastic. And please let me know if there's any questions or concerns that I can address.
Thank you so much, Dr. Vasudevan. That was a fascinating presentation and so full of hope. Really thank you for putting that together for us. That part about the surgery where the patient is awake is just fascinating. I saw that on a documentary not that long ago. So the fact that that's happening at Northside in our own backyard is just amazing. And I also really appreciate your approach to patient care, where you said, see the whole patient. As a social worker, that is so important to know that there is more than just a tumor. There's a whole patient there who has values and beliefs that need to be taken into account. So I very much appreciate your approach to that. We do have a question in the chat. Let's see. Is it still uncommon for prostate cancer that has already spread to the lungs and liver to progress to the brain?
I will say that prostate cancer in general, spreading to the brain for reasons I think don't fully understand, it is a rare thing. So of course, once you are already diagnosed with metastatic cancer, that increases the likelihood that you might have spread of that disease to the brain and to the spine. But again, prostate cancer within the brain tissue itself is a fairly rare thing for reasons that I think are beginning to understand, but don't fully understand. I have seen prostate cancer that has spread to some of the tissues around the brain, including the skull and the lining of the brain, but that would be very uncommon. With prostate cancer, it is more common once it has already reached a metastatic stage to spread to the spine. So that would be an area that we see it more commonly.
Thank you. And a question that came up for me, because I've frequently heard from patients who will say, well, I have lung cancer and brain cancer, and wanting them to, trying to get them to understand whether or not it is two separate cancer diagnoses or whether it's metastases. Do you have any way of guiding patients on how to talk to their doctors about what their disease is and how to identify it?
Yeah, what I would say is I agree with you. That's a very common thing that I hear as well. And I think it is something that I certainly understand, because that is a more easily digestible way for patients to understand it, which is I have lung cancer and that cancer has spread to the brain, so therefore I have brain cancer. But it is, I will say a couple things. It is exceedingly different, as I pointed out, that brain cancer has to be distinguished from cancer that has spread to the brain. So I would tell folks who have this diagnosis to tell people that I have lung cancer that has spread to the brain, or I have metastatic lung cancer to the brain, or stage 4 cancer to the brain is another way to say it. Because brain cancer in and of itself is a very distinct, special thing. It would be exceedingly, exceedingly rare to have brain cancer in addition to lung cancer. To have two separate cancers would be a very, very rare thing to have. I hope that answers your question.
Yes, absolutely. Thank you. Another question in the chat, can you revisit a radiation-treated tumor with a second or even third radiation treatment?
Yes, that is possible. It depends on a lot of different factors. So, for instance, it depends on the particular kind of radiation that may have been administered before, the dose of radiation that may have been administered, and where that particular tumor is located. As I told you before, everything in the brain basically boils down to location, location, location. And inevitably, when we treat something with radiation, there's always a minor degree of spillover of that radiation to the surrounding tissues. So, for instance, if somebody has had a tumor that has had radiation in an area of the brain that is very sensitive, say it controls language function or movement, we might think twice about radiating it again because the risk of damaging some of those normal areas of the brain with the radiation goes up. But it takes a detailed discussion again with a team that is used to doing this quite often to elucidate that. So once you have had radiation and we're considering a second round of radiation, it becomes a much more nuanced decision-making process.
Thank you. If anyone else has any questions, please feel free to enter those in the chat now. I did just want to do a quick overview of Cancer Support Community Atlanta and the services that we offer. We are part of we are the local network provider of the largest provider of oncology support programs in the world. We offer a variety of programs and classes to support cancer survivors and their loved ones. Dr. Vasudevan talked about how important it is for caregivers to be a part of the treatment process. And we, of course, want to help caregivers through that as well with our support services. All programs that we offered are led by licensed professionals and are evidence-based and offered free of charge. It also doesn't matter where you were treated, and everyone is welcome to participate in our programs, but we have been affiliated with Northside Hospital for over 20 years, which we are very proud of. So thank you for allowing me to talk about our programs for a little bit during this presentation. Just a comment in the chat, awesome presentation. Thank you for sharing. We do have another program next Friday, May 20th at 12 p.m. on colorectal cancer and genetics, and that'll be done by a genetic counselor through Northside Hospital Cancer Institute. So if you are interested in how genetic counseling might affect you, if you have been diagnosed or colorectal cancer runs in your family, definitely check that program out. Again, that's next Friday, May 20th at 12, and you can register on our website, cscatlanta.org. All right, it is just after 1, so I want to be mindful of Dr. Vasudevan's time. I'm just seeing some thank you in the chat. Just so everyone knows, this program was recorded today and will be posted on our website, cscatlanta.org, under videos in the coming weeks. So you will be able to have access to that if you want to share that or just rewatch it, because there's some really wonderful information shared here. But Dr. Vasudevan, any closing thoughts?
No, again, I thank you so much for the opportunity, and I encourage folks again to reach out, and if we can be of any help. We do a lot of virtual visits and things like that these days, and even if it's just as simple as looking at a scan and needing a phone call or an opinion, we're happy to do that. So please don't hesitate.
Absolutely. Again, it's so reassuring to know that such expertise is located right here in Atlanta. So thank you again for sharing your expertise today and doing this program for us. And I thank everyone for joining, and have a wonderful rest of your Friday and a wonderful weekend.
Thanks, everyone.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.